Welcome to the Sports Docs Podcast. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan.
On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice.
On today's episode, we're focusing on medial collateral ligament injuries with Dr. Brett Owens. We have some great articles for you that contribute well to our conversation on MCL tears, including clinical evaluation and workup, treatment options and outcomes, and importantly, prevention. As always, links to all the papers that we discuss on the show can be found on our podcast website, www.thesportsdocspod.com.
We'll start off our discussion today with an article authored by our guest, Dr. Brett Owens, titled The Epidemiology of Medial Collateral Ligament Sprains in Young Athletes from the 2014 issue of AJSM. The authors performed a longitudinal cohort study of U.S. military cadets and found that MCL injuries are relatively common in the athletic population. Male athletes are at significantly greater risk than females. Of the 128 injuries in this study, 89% occurred in males. Intercollegiate athletes are also at greater risk than athletes participating in intramural sports, and the incidence of MCL injury was highest in wrestling and hockey. In terms of time missed, the average amount of time was 23 days, but this really differed based on grade of injury, with grade 1 sprains only missing a median of 13.5 days.
Up next is a current concepts review article from JBJS authored by Dr. Robert Laprade and colleagues at the University of Minnesota. Some takeaways from this paper. First, the medial structures of the knee, including the superficial and deep MCL, as well as the posterior oblique ligament, are the most commonly injured ligament structures of the knee. The majority of medial knee ligament tears are isolated injuries. Physical examination is the initial method of choice for diagnosis and includes application of valgus load to the knee in both full extension as well as 20 to 30 degrees of knee flexion. In terms of imaging, valgus stress radiographs and MRI are useful to compare the grade of injury.
We wrap up part 1 with a discussion on the prevention of MCL injury, and we review an article from the August issue of AJSM this year titled Prophylactic Knee Bracing and Offensive Linemen of the NFL, a retrospective analysis of usage trends, player performance, and major knee injury. Dr. Robert Gallo and team at Penn State found that brace wearers had a significantly lower rate of major knee injury, defined as an injury requiring time missed. The most common knee injury in non-bracers was an isolated MCL injury. There was no difference in player performance between bracers and non-bracers, and interestingly, despite this data, brace usage has steadily declined from 16.3% in 2014 to 5.6% in 2020, specifically at the rookie level.
We are joined today by Dr. Brett Owens, a board-certified orthopedic surgeon at University Orthopedics in Providence, Rhode Island, who specializes in complex shoulder, knee, and sports medicine. He is the Chief of Sports Medicine at the Miriam Hospital in Providence, Rhode Island, and Director of Rhode Island Cartilage Repair Center. He is a professor of orthopedic surgery at Brown University, Alpert Medical School, and is currently a team physician for Brown University and the Providence Bruins.
Prior to joining University Orthopedics, Dr. Owens served as the Chief of Orthopedics and Sports Medicine at Keller Army Hospital in West Point, New York, where he cared for soldiers and cadets at the U.S. Military Academy and was the team physician for Army lacrosse, rugby, and football. While deployed in Iraq during Operation Iraqi Freedom, Dr. Owens served as the Chief of Orthopedics at the 86th Combat Support Hospital. He has also served as a team physician for USA Lacrosse, like Catherine, and needless to say, he's incredibly accomplished. So we're really excited to have him join us today. Welcome to the show, Dr. Owens. Seeking a clinically proven solution for your patients with massive and irreparable rotator cuff tears that has the potential for early functional recovery and pain relief? Check out InSpace.
InSpace is the industry's only minimally invasive, biodegradable subacromial balloon spacer for the arthroscopic treatment of massive, irreparable rotator cuff tears. InSpace is designed to restore the subacromial space without requiring sutures or fixation devices. Learn more at stryker.com/InSpace.
Welcome to the show, Brett. Thank you so much for taking the time to join us today and share your expertise with our listeners.
Ashley, Catherine, thank you so much for having me. It's great.
Excellent. So we'd like to start off a discussion today with a little bit about epidemiology of MCL injuries. And you were the senior author on an epidemiologic study that investigated the incidence of MCL injuries in U.S. military cadets, looking at breakdown based on gender, type of sport, et cetera. So we wanted to start there. So can you give us an idea of the patient you're typically seeing with an MCL injury?
Yeah, sure. So it's always fun to start with the epidemiology. I mean, it's something that kind of gets glossed over a little bit, and I appreciate you picking that article. If I guess three people have read it so far, so that's good. Um, it was interesting. I mean, doing the study at West Point, where it's a very captive population. That these kids couldn't go other places and they had to participate in sports or have an excusal written by the docs there, so it was really easy to know who was returned to sport or not. And we've used that to look at many injuries. MCL was a fun one to look at. And I don't think our findings were really shocking. We found it most prevalent in our certainly in our intercollegiate sports, but in our collision sports, right? So it's wrestling, it's football, hockey. It was very predominant, and we see that. It's not surprising because we see that in other injury patterns in the knee as well as in other body parts. So, the interesting finding about that study, that the take home for me really was to be able to help counsel patients a little bit on the return to sport time frame. So we found that your low grade injury was able to return. Grade 1 was able to return at 2 weeks, and then the higher grade 2 and 3 injuries took about a month to return to sport. So that can be helpful a little bit if you want to counsel some patients, maybe, and set their expectations a little bit more appropriately when you get that diagnosis.
Yeah, I think that paper does provide a great overview. And I actually did. So, I was a physical therapist for a little while, and I sort of took, as I was, early in that career, and I was starting to think about, do I want to go back to med school? Do I want to do a PhD? There was a short, brief period of time I thought about doing epidemiology and like doing that PhD sort of route, which I'm glad I didn't, but it is very important. So, but I had a question. I don't think this was reported in the paper, and I just sort of thought of it as you were speaking. Yeah. Do you guys ever notice, and Brett, we'll start with you, anything about time frame, like preseason, in season, towards the end of the season, that you're seeing MCL injuries, or nothing that you've ever felt like, oh, that, there's a repetition there and a trend?
It's a great question. I don't think I've had that posed before or really thought about it before. I think these are usually contact injuries, right? And so when we see non-contact MCL, it's usually in combination with a cruciate, ACL failure, where we'll see. It's always surprising to see non-contact ACLs that also have an MCL component to it, which is kind of interesting. Unlike the ACL, I don't know if it's ever been reported to look at seasonal variation of the MCL. As we see it, a couple of different spikes in ACL injuries. We'll see it sometimes early in the season, then we'll see it certainly later in the season, and we'll see it later in the games, right, with fatigue of the musculature. But I don't know, and that MCL's injuries are usually contact. So actually.
Yeah.
No, I think you hit the nail on the head. I was going to say exactly what you said, which is because it's mostly contact. It's like wrong leg position, wrong place, wrong time type of a situation where I'm not sure. I mean, maybe you could say maybe in playoffs, people were playing more aggressively. Maybe they were contacting more, a little bit of a rougher play. Maybe we're seeing a spike there. I don't know. I'd be curious to see that. But I agree. I think you're seeing more of that kind of peak in preseason and then late in the game relating to deconditioning from, for ACL tears. So I think kind of exactly what you said. Catherine, what's your experience? Do you see you take care of a lot of skiers. Do you see a lot of like a seasonal pattern or a pattern based on timing?
I see a lot of beginning of the season ACL and MCLs, but a lot of it, I think it's multifactorial because there's a lot of condition type things. So it's, there's a little base of snow. We'll call these certain areas like white ribbons of death because it's like, you know what I mean? It's just like, there's snow, but it's not really like robust. And there's only certain, trails open. And then, you get a flock of people who are like good skiers. And they just like, I did an ACL today on a girl who's an excellent skier, does a ton of backcountry stuff, like heli-ski, and got nailed like on a green and, just blew up her ACL. So, you know what I mean? I think there's other factors, but I was wondering, there's so much of that digging in all the NFL literature that, obviously many folks have done. Ashley and I definitely did some of that when we were residents under Preventure. looking through those troves of data to try and see, when did all these things happen, how often, all these types of stuff. So maybe it's already out there in the NFL data and I'm just not aware, but I don't know.
I think it's really interesting, Catherine. I think, we always try to identify risk factors, right? And that's what a lot of those NFL studies do. Is it positional? Is it linemen? Is it offensive linemen, defensive linemen, wide receivers? And we've done that a lot on our mini episodes that we do. Yeah. And so definitely, I think there's still a lot more to learn about this topic, even if it isn't as flashy as ACL.
Yeah. But yeah, agree. Yeah. Go ahead, Ashley. You're about to ask a question.
Yeah, I think that this is a good transition point into talking about like how we diagnose these. So I know there's obviously patient walks into your clinic, you're going to start with a physical exam, Brett. So can you walk us through your physical exam for someone with a suspected MCL injury and how you're going about grading them?
Sure. So, you need to, the physical exam starts when you watch them walk in the office, if you have the ability to visualize that. But, I do a full, soup to nuts exam on the lower extremity, making particular points to look at their alignment, etc., as well as their movement patterns, if you're able to visualize that. I have a pretty standard MCL exam, like most folks, where I check in full extension, to resistance to valgus stress, and then also at 30. The only thing I do add to it that might be a little bit different is I usually will incorporate a thing called a Swain test, SWAIN, which Dean Taylor taught me. It's an old a test designed by one of the physical therapists at West Point, but it's basically if you hold the leg off the table and the knee is at 90 degrees, you externally rotate the foot, and that can put some strain on the POL. I find it really helpful in that athlete. Maybe that feels like they're ready to go back and they're getting pretty sticky and have good resistance to valgus stress. But then you put that torque on them and really, positive test is really pain, in that position. I grade it similar to most with, side to side difference 0 to 5. Millimeters, 5 to 10, beyond 10. I mean, it's always critical with my fellows and residents. I really stress the importance of always start with your normal knee exam, right? Just so you can get your baseline, right? And so it's always shocking. You see some of these knees that have a huge amount of medial lateral toggle on your collateral exam, and with a 20 degrees of recurvatum, a physiologic pivot shift, and that's just the way they're made, right? And so you have to grade everything based upon where they usually live.
Yeah. I also think, just on a side, it must have been really nice to train under Dean Taylor. Ashley and I are both on a committee with him right now. And just, it feels like a luxury, just to sort of spend some time with him and learn from him. And, so.
Yeah,
I don't know.
Oh, he's great. Yeah, no, he's great. We've been really blessed that, the folks that I was able to work with and be mentored by at the military academy were really fantastic. And it's a really, he's a super mentor, to so many, and we're so lucky.
Yeah, no. And we've had him on the show before, so hopefully we can get him back at AJSM next year, but he was fantastic.
Yeah.
So we haven't talked about valgus stress radiographs. So those are, obviously used sometimes for diagnostic purposes. Sometimes it's for surgical decision making. I trained under Laprade for my fellowship, so that's sort of drilled in your head. And my sort of predisposition is I'm using them less in clinic and more in the OR if I'm, sort of something feels like a little bit of a tweener, or I just want to get a little bit more proof that no, I don't need to, say do this. I don't need to address the MCL and the OR, or no, I do. So it gives me a little bit of data there. But Brett, how, if at all, are you using stress radiographs?
Yeah, I don't use them. I experimented a little bit early in my practice, based upon some of of Rob's, great published work, but I just haven't found it to be practical or really useful for me. The one scenario where I will do stress radiographs is usually with live fluoroscopy, right? And so if I'm doing that unique, I actually did one a couple weeks ago, but it's pretty rare for me. But if it's a really confusing picture, or I'm doing something else, doing a diagnostic arthroscopy, I'll, usually complex revision situations, I'll do, a dynamic fluoroscopic exam under anesthesia. But I don't routinely use stress radiographs. Tell me, Catherine, how does it help your decision making? I know you said you mainly use it in the OR, but how about in the office?
So I would say when I first started out in the office, like right out of fellowship, I was doing them pretty routinely, especially not so much in this topic for MCL, but for posterior lateral corner. I was using them a lot for varus stress and, just sort of helping I think really just sort of build my foundation of what, that side to side comparison, where am I over sort of thinking this, is this really not as loose as I think it is, so I would say as an early clinician, it was really helpful to have sort of another data point just to either, sort of confirm my decision that no, this does not need to be addressed, or, make me think a little bit further. But what I also found in the clinic was, they're guarding a lot. And, if they're in pain. So the clinic value was also, a little less helpful, I found. And that's probably the population of, the people coming off the mountain, when you're seeing them and kind of doing that first workup, their knee's still a little angry. So the value, I think, I was finding it to be a little bit diminished over time. And Ashley, I think you do use it a little bit, don't you?
So it's funny, very similar to you. In my early phase, I was using it as an additional data point that if people were guarding, or if it was a really large lineman and I felt like, was I really getting a true exam? Was it really a grade 3 or was it a grade 2? I would do stress radiographs because we have our x-ray in our clinic. So I was able to do that as a check. And also, going into board collection as another data point showing, hey, look, this is actually a grade 3 complete injury to the superficial and deep MCL and possibly warrants a surgery. So I think that was very helpful. In the OR, I use it again as a check, just to kind of confirm once they're relaxed. I demonstrate how much gapping there is, and then I do a test at the end, just gentle, not trying to crank it, but just to demonstrate the stability has been achieved. So I think it's just an extra data point, which I think can be really helpful, especially for those tweener cases, but especially early on in your career when you're just trying to confirm your physical exam. So then, Brett, you mentioned, we talked about radiographs, but we're all getting MRIs, right? So you're getting an MRI typically in this patient. What are you looking for on the MRI? Are there associated injuries you're typically looking for? Is there a certain pattern of an MCL tear you're looking for to kind of distinguish between something you can treat non-surgically versus taking them to the OR?
Yeah, and I do recommend MRI. And in my practice, if you tear a ligament, you're usually getting an MRI, and especially traumatic injury like that, because we all miss concomitant injuries, and I've missed ACLs, meniscal tears. I get this question asked a lot by colleagues, or you see them later for another opinion, and they've never gotten the MRI. And there's more to the picture than just a isolated MCL tear. So I think it is really important, to, especially acutely, to be able to determine. I really look for the location, right? And the location is hugely impactful for me. Tibial-sided lesions, as you know, can be notoriously slower to heal, and also there's the risk there of having a Stenner type lesion, the so-called Stenner lesion, where it flips over the pes, and in that case, it's not going to heal as well. And I am a lot more aggressive with the tibial-sided lesions.
Yeah. So before we dive into, how we're going to treat all these MCL tears, we want to talk a little bit about prevention. So there was a study out of Penn State published in AJSM earlier this year on NFL offensive linemen who wore prophylactic knee braces, and they had a significantly lower rate of major knee injury. So obviously we can dive a little bit into the study and, what do we think about how it was done and, how they pulled the data. But, for you reading a paper like that, does that change how you're, prescribing prophylactic knee braces? What are, your opinions on that?
Yeah, I really applaud the paper. I thought it was great. I thought you were going to segue into it earlier when we started talking about, NFL experience. I will come out with a couple of disclaimers. I am part of the NFL musculoskeletal injury committee, and I did So, officially, this is not sanctioned by the NFL. They've really tried to clean up or at least police a lot of the. There's a formal process for putting these papers through now, and this was not, an official, because it's hard to get data out of the NFL. That's the challenge. It also to be approved by the, by the teams, by the league and the players, and with the collective bargaining agreement, that can be really tricky. And so, these so-called publicly accessible papers, I think there's value in them. I know they've been critiqued a fair amount, but I think there really can be some value, and they use publicly accessible video analysis and publicly accessible reports to look at the injury patterns. I think it can be kind of cool. I looked at, we wrote a paper through the committee. Rob Brophy and I looked at every video analysis of every ACL tear in the NFL. So it definitely is a laborious work to do those video analyses. But and some of the similar findings here, right? It's the linemen that get rolled up on, that have contact, at least MCL, sometimes multi-ligament ACL, MCL, injuries, as opposed to position players, and that's where most of the data is on prophylactic bracing. And this study kind of confirms a body of evidence. The West Point study by Sittler, that used a single upright hinge, John Albright's work in the Big Ten, and there have been other studies that that really show the value of the dual upright brace, usually for linemen, and most D1 and pro players, use that. The interesting thing about this study is, you didn't see as many braces used in maybe the early players. It was more like the veterans, right? Which I always think is interesting. Maybe I'm not sure why that is. Maybe they didn't want to be slowed down by the brace. Maybe early older players maybe are more concerned about safety and longevity.
Yeah.
Yeah. Do you think that's why? Because that's something that I found interesting. Is they found that the brace wearers had a lower incidence of major knee injury. Yet from through the study timeline, the brace usage was declining over time. So that was perplexing to me, that it can maybe lower the risk of injury, but brace usage was declining. Like, why do you think that was?
Well, it could be an education thing. It's also, look, I mean, it's a game of speed, like all these games are, and anything that hinders you is going to be, pared down, right? I mean, you have to look past, the knee and thigh pads in the NFL now to it's all about speed. And anything you can do to trim back some of the protective gear, you're going to usually make that compromise. And obviously, the players are concerned about safety, but it's about performance, right? And it's also they're going to make it's nice to give them the information, but there's superstition, there's strong opinions about what feels good on them, and if they can't do their job, right, they don't feel comfortable in that brace, then it's going to be a no-go for their performance.
Yeah. And I'm sure you saw that in lacrosse too, where
Sure.
the amount of protective equipment really just declines as they get, more far along. Like if you look at them in the pro leagues, they're wearing such minimal protective equipment, and you sort of think, gosh, don't you worry about X, Y, or Z? But the focus, I think, especially at that young age, is just on performance, and this holds me back, or maybe there's a style thing as well going on. But
they don't wear shoulder pads. I mean, at the pro level, it's like, aren't you concerned about that? But no, it's all about hindrance of their performance, right? And you can share the data, but they're gonna make their decision.
There was one gentleman that I took care of in the PLL who would wear full shoulder pads, chest pad, and I was always like, so happy, that he did. And I talked to him about it, and it was because when he was coaching, he was like an assistant coach at a college level. One of their guys got hit in the chest, and he was there while they were doing compressions on the kid. Oh my gosh. And it was just, the kid survived. But you know what I mean? I think like that's most people are like, that'll never happen.
Yeah.
But
it happens.
Yeah, it does. But yeah, I think you, Ashley, I don't get a ton of football players in my clinic. It's just not a big part of what folks are doing. There's some flag, but there's just not a lot of heavy football here.
Yeah.
But what about you? Are you sort of telling people prophylactic bracing or?
They're kind of bringing it up themselves too, because a lot of the high-level football players I take care of that are looking to go to D1 schools or play throughout college are seeing the D1 players wearing braces. They're seeing all the linemen with their matching braces, lined up, and that it's almost kind of counter to what we just saw in that study where brace usage was declining. They look at that as those guys are doing it. I should be doing it. If they have that protection, I should have that protection. So I'm having a lot more parents asking about that. And the tricky thing is sometimes getting that through insurance. Like if I do an ACL, getting a brace covered is no big deal, PCL, MCL. But if it's bilateral and it's prophylactic, sometimes that can be a little bit challenging. But people are definitely bringing it up. But yeah, I take care of a lot of football players, and they kind of welcome the protective equipment. The wrestlers, on the other hand, do not. I had many wrestlers tell me that protective equipment just signals to the other player that's where you should attack. So they don't wear anything on like elbows or knees or anything like that for fear of that being targeted. So I think it differs, player to player and sport to sport, but my football players are definitely interested in this.
Brett, were you a wrestler?
No, I was not. I was a very undersized football player. I would say the difference actually is that the pro at the pro and the college level, this is paid for by the team, right? And so I agree. Prophylactic bracing at the high school level is usually very individual, and it's usually not, unless it's a big time private school program, they're usually not supporting that.
Yeah.
Now, Brett, if you have an athlete that's had a high level, let's say it's a grade 3, but it was able to be treated non-operatively, is that someone that you would perhaps recommend, like, hey, you should consider a prophylactic brace because you've had this injury? Or do you deem them, like, if they're healed up and they've successfully completed their rehab, they're as much at risk as someone who's never injured their MCL? Would that change your discussion?
I'm usually getting them back to play in a brace. So before they've completely healed up, they have purchased that brace because it's allowing them to return to play earlier, right? So usually with an MCL, if it's like the following season, I wouldn't usually recommend necessarily that they continue that brace. Is kind of up to them as how they feel with it, right? And certainly if they're a high risk position like an interior lineman, I think the dual upright brace is a good option for them. Yeah.
Thank you for listening to this episode of the Sports Docs. We hope you enjoyed the first part of our discussion as much as we did. On the next episode, we'll continue our conversation with Dr. Brett Owens and shift our focus to treatment of isolated and combined MCL injuries. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and now on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocpod and Twitter at thesportsdocpod, no S. We love your feedback.